Welcome to Genitourinary Cancers. I'm Lisa Hawley, an Associate Clinical Professor at the UConn School of Pharmacy, and I practice at the UConn Health Mieg Cancer Center. My faculty disclosures are listed here for you. These are the learning objectives for the genitourinary module. This webinar will focus on primarily objectives 3 through 5, the treatment and toxicity prevention, monitoring, and management. We will talk about 4 genitourinary cancers. The first is bladder cancer. We will begin with this cancer, which will be categorized really into 2 main types of bladder cancer, the non-muscle invasive bladder cancer and muscle invasive bladder cancer. Within each of these categories, the histology, grade, and depth of invasion will dictate treatment based on what we know about the likelihood of recurrence and progression of tumor based on these factors.
All patients with non-muscle invasive bladder cancer will initially undergo a TURBT, that is a transurethral resection of the bladder tumor. This is followed then by first-line intravesical therapy. Once the clinical stage is determined, adjuvant treatment is initiated based upon that clinical stage. As you can see, BCG is often preferred, particularly for those patients with clinical stage TA that is high grade, as well as clinical stage T1. For those with residual disease, it is considered a Category 1 recommendation by the National Comprehensive Cancer Network. And for those patients with no residual disease, it is a preferred regimen. The addition of intravesical therapy has been shown to reduce rates of recurrence only, not reduce progression or mortality. And typically, gemcitabine or mitomycin are used when chemotherapy is used for intravesical therapy. Overall, the goals of therapy are to reduce recurrence and delay progression to muscle-invasive bladder cancer.
Now, let's talk a little bit more about the first-line treatment using intravesical therapy. Immediate intravesical therapy is given within 24 hours of the surgical removal of the bladder tumor, but ideally it is done within 6 hours because overall outcomes are better when it's done more quickly after the surgical procedure. Typically, gemcitabine or mitomycin are used most commonly. Induction intravesical therapy or adjuvant intravesical therapy is typically initiated 3 to 4 weeks after the surgical procedure. BCG, a mycobacterium that is effective in non-muscle invasive bladder cancer, or chemotherapy agents like gemcitabine or mitomycin are used. Typically, this is administered as weekly instillations for 6 weeks. Maintenance intravesical therapy is typically given with BCG alone, and it's 3 weekly instillations given at months 3, 6, 12, 18, 24, 30, and 36. Based upon the ongoing drug shortages with BCG, split doses or lower doses of this agent is often used to be able to maintain this intravesical maintenance therapy treatment plan. Following treatment, patients are evaluated to see if there is a complete resolution, and if not, a second cycle of induction or adjuvant intravesical therapy may be given. And those with persistent disease, maintenance therapy might be the mainstay of therapy.
The second-line treatment of non-muscle invasive bladder cancer, again, will depend upon the clinical stage. Those with clinical stage TA or TIS will undergo a TURBT, and then depending on whether or not there is residual disease, that will guide treatment. No residual disease results in maintenance BCG therapy to try to keep that progression to muscle-invasive bladder cancer from happening. In those patients with residual disease after the TURBT, there are different options. One is including different intravesical agent administration, such as agents like valrubicin, epirubicin, docetaxel, and gemcitabine, or either sequential or combination chemotherapy. A cystectomy is also an option in some patients who can tolerate that and are willing to undergo a cystectomy. Most recently, pembrolizumab has been shown to be effective based upon the results of the KEYNOTE-057 trial. This trial showed that after 3 months of therapy, a complete response was obtained in 40% of patients, and in those patients, those responses were durable, lasting for at least 14 months, although the median duration of response has not been recorded yet. Clinical trials are always an option in these patients as well. Those patients with high-grade clinical stage T1 tumors, though, must undergo a cystectomy to have the best outcome. And in patients where surgical options are not an option, chemoradiation therapy can be used.
Now, BCG is a mycobacterium that induces systemic, non-specific immune stimulatory responses, which is effective in these bladder cancers that are confined to the non-muscle invading. But as you well know, whenever you stimulate the immune system, that can lead to secretion of pro-inflammatory cytokines. That can result in flu-like symptoms, which typically last for about 48 to 72 hours following administration. It also can result in bladder discomfort. Patients describe it very much like a urinary tract infection that is irritating. And this occurs in about 60% of patients. Anticholinergics or quinolones can be used in these patients to help with that discomfort. There's been some data to support that a dose reduction in BCG of up to 1/3 may actually help with symptoms, although when you look at the clinical trial data, there are mixed results with that. But that may be an option, and with drug shortages, we may be doing that anyway. What's important to know that it's extremely important to withhold treatment if any of the following occur. If there's traumatic catheterization, if there's a bacteria, persistent gross hematuria, persistent severe local symptoms, or systemic symptoms. All of these pose a risk to the patient if you continue BCG toxicity, where they could develop a systemic mycobacterium infection. Now moving on to muscle-invasive bladder cancer. The first-line treatment is going to depend upon the stage, and the goals of treatment will also depend upon the stage. Those with early-stage disease, our goals of treatment are to increase overall survival time and have disease control. But those with metastatic disease are considered to be incurable, and the goal of therapy is to palliate symptoms. In stages 2 or 3, neoadjuvant chemotherapy followed by a radical cystectomy or removal of the bladder based on a meta-analysis of 11 trials has shown a 5% absolute survival benefit after 5 years. So because of this data, it is considered the standard of care. There's no preferred regimen, although dose-dense MVAC or gemcitabine or cisplatin are the 2 regimens that have been used and evaluated, but have been not compared head-to-head. And in this setting, carboplatin should not be used in substitution for cisplatin in patients who have renal dysfunction or other contraindications to cisplatin. Now, adjuvant chemotherapy in stage 2 or 3, the data is much less clear. It may delay recurrence and improve overall survival, but no randomized clinical trials have been conducted, and a meta-analysis of retrospective data suggests the overall survival benefit may occur, but patients didn't receive neoadjuvant therapy in that setting. Therefore, we typically reserve adjuvant chemotherapy for patients who did not receive neoadjuvant chemotherapy and may have had more advanced disease determined at the time of cystectomy, or those who have high-risk pathology like lymphovascular invasion, etc. Bladder-sparing approach may be preferred for patients who are not candidates for a radical cystectomy or prefer not to have a radical cystectomy. And that would include chemoradiation therapy. Typically, the regimens that are used are cisplatin plus fluorouracil, cisplatin plus paclitaxel, or fluorouracil plus mitomycin in combination with radiation therapy. In patients with stage 4A disease, those are patients who have extra pelvic area disease, metastatic disease, systemic chemotherapy for 2 to 3 cycles or concurrent chemoradiation therapy is recommended. In those patients, then we would reassess after 2 to 3 cycles or the completion of their chemoradiation therapy. If they have no disease, we would consider using consolidative chemotherapy or do a cystectomy to try to improve overall disease outcomes. In those patients who have persistent disease, we would either complete the definitive chemoradiation therapy or perform a cystectomy. In those patients with widely metastatic disease, the current standard of therapy is systemic chemotherapy or concurrent chemoradiation therapy.
In patients with muscle-invasive bladder cancer that has metastasized, the first-line treatment depends upon whether the patient is eligible to receive cisplatin. Reasons that a patient may be ineligible to receive cisplatin include hearing loss, renal dysfunction, poor performance status, or those patients who might have cardiovascular disease prohibiting them from being able to receive the high volume of fluids that is required with cisplatin therapy. As you can see, there are two options, dose-dense MVAC and gemcitabine cisplatin. They have not been compared head-to-head, but overall, these regimens increase overall survival by 9 to 15 months compared to other regimens that have been used previously. For patients who receive a complete response or stable disease, maintenance therapy with the checkpoint inhibitor avelumab has been shown to improve overall survival by 7 months and is now considered standard of care in the treatment of metastatic muscle-invasive bladder cancer. In those patients who are ineligible to receive cisplatin, they can either receive gemcitabine plus carboplatin, followed by avelumab maintenance, or they can receive an initial checkpoint inhibitor monotherapy with atezolizumab or pembrolizumab. Gemcitabine carboplatin has an improved overall response rate when it was compared with a regimen of methotrexate, carboplatin, and vinblastine, somewhat similar to that dose-dense MVAC regimen, and it improved overall survival, but not significantly. For patients, again, with a complete response or stable disease, the avelumab added to the gemcitabine carboplatin improves overall response rate by 7 months. Checkpoint inhibitor therapy alone has a median overall survival that is improved compared to those patients who did not receive that. Subsequent line treatment of metastatic disease, that is muscle-invasive bladder cancer, will depend upon what they received initially for first-line treatment. In those patients who did receive a platinum therapy, it is recommended that an immune checkpoint inhibitor therapy be used, with pembrolizumab having an NCCN Category 1 recommendation, based upon the results that it showed an improved overall survival, and there was a longer 1 and 2 year overall survival and progression-free survival compared with chemotherapy. Now, it is important to note that a small percentage of patients with muscle-invasive bladder cancer will have a mutation in the fibroblast growth factor receptor, or FGFR. In those patients, they can benefit from receiving the targeted agent erdafitinib. In patients who received initial therapy with a checkpoint inhibitor, then you would receive or recommend receiving a cisplatin-based regimen if they are cisplatin eligible, or gemcitabine carboplatin if they are cisplatin ineligible. Following second-line therapy, there is a new drug called enfortumab vedotin. It is used for patients with metastatic disease who have progressed after immunotherapy and a platinum regimen. It is an antibody-drug conjugate, a first-in-the-class type drug that's directed against cell adhesion molecule Nectin-4 that is located on the surface and highly expressed in bladder cancer. This antibody directs the product to these cells and then releases the cytotoxic agent monomethyl auristatin E. It has an overall response rate of 44%, with about 12% of patients having a complete response and a duration of response of 7.6 months on average. Again, patients who have FGFR positive mutation can receive erdafitinib as well.
There are some key supportive care management things that you must remember about bladder cancer. B12 deficiency is very common after bladder resection. This is because bladder resection with a urinary diversion using an ileal conduit or a complete neobladder will likely result in B12 deficiency. And this is because a limited part of the ileum is available following this surgical procedure, and that allows for some absorption, but not complete absorption, of oral sources of vitamin B12. Thus, vitamin B12 levels should be checked annually beginning 1 year after surgery, and cyanocobalamin supplementation should be administered either intramuscularly or subcutaneously if levels are lower than the normal limit. The oral forms will not be absorbed. That's why we have to give it by these other routes. And this treatment is given for the remainder of the patient's life. Nephrotoxicity is also a big concern, particularly with the cisplatin-based regimens. All patients should be hydrated adequately pre and post cisplatin administration, as well as supplemented with potassium and magnesium as needed and closely monitored. Those patients who are at high risk of developing nephrotoxicity, such as moderate renal dysfunction at baseline, other diseases which have the propensity to cause renal dysfunction like diabetes, should be considered. And those patients who have borderline or minimal renal dysfunction could have their cisplatin dose split So instead of 70 milligrams per meter squared per dose on day 1, it could be 35 milligrams per meter squared per dose on days 1 and 2, or given on days 1 and 8 to try to minimize the potential for nephrotoxicity. Febrile neutropenia is common, particularly with dose-dense MVAC, and data supports the use of colony-stimulating factors routinely for prophylaxis with this regimen. It only should be used with other regimens, though, if they meet the criteria for prophylactic use of colony-stimulating factors. In those regimens that contain an anthracycline, such as dose-dense MVAC, we need to monitor those patients for cardiotoxicity as well as a cumulative dose. Now we're going to move on to renal cancer, and this will focus primarily on renal cell carcinoma. In renal cell carcinoma, the most common type of kidney cancer, clear cell histology is the most common, and cure is very possible, particularly with stages 1 through 3. And indeed, this is the goal of therapy for those stages of renal cell carcinoma. In patients who have metastatic renal cell carcinoma, the goal of therapy is to control disease burden, prolong survival, and maximize the quality of life. Surgical excision for stages 1 through 3 is the primary mode of treatment in these patients, and that is to help with the disease control by removing the tumor itself. You can see with stage 1, it is an NCCN preferred recommendation to do a partial nephrectomy, just removing that tumor itself. In stage 1, you can also use ablative techniques, typically used primarily with T1A tumors, and that includes cryoablation and radiofrequency ablation. That allows you to preserve the kidney so that a partial nephrectomy can be accomplished. Stage 2 and 3 partial nephrectomy is done when the tumor is less than 7 centimeters, if the patient has a solitary kidney or impaired renal function or other comorbidities exist. Otherwise, you might consider a radical nephrectomy. In stage 4, nephrectomy is only done when we want to try to reduce the tumor burden and if it's feasible. Now, with early stage disease, typically when we use the primary mode of therapy of surgery, adjuvant therapy is administered with it to improve overall disease outcomes. Renal cell carcinoma is one of those diseases where adjuvant treatment is not recommended except for a select group of patients of stage 3. And the data is with the drug sunitinib based on the S-TRACK trial. This is a trial that was conducted in patients with stage 3 high-risk renal cell carcinoma of clear cell histology. Sunitinib, an oral tyrosine kinase inhibitor, was administered as 50 milligrams by mouth daily for 4 weeks as a treatment regimen of 2 weeks off treatment and 4 weeks on treatment. And this was compared with placebo given for 1 year following a radical nephrectomy. What this study showed was a median disease-free survival was prolonged with this administration of adjuvant sunitinib. The disease-free survival with sunitinib was 6.8 years versus 5.6 years with placebo, but was not statistically different. No overall survival benefit was shown, and grade 3 or 4 adverse effects were more common, as you might expect compared with placebo, almost 3-fold more common. Based on this data, because it wasn't statistically significant in terms of disease-free survival prolongation and no overall survival benefit was determined, it's only considered an NCCN category 2B recommendation. So it is a possibility for adjuvant treatment, but is not recommended for all patients with stage 3 disease. Now, as we move on to the treatment of metastatic renal cell carcinoma of clear cell histology, it is based upon prognostic factors and the risk that these patients have for progression of disease. These 2 risk models have been developed. The most common is the one on the right, the Memorial Sloan Kettering Cancer Center prognostic model. The one on the left is the International Metastatic Renal Cell Carcinoma Database Consortium prognostic model. As you can see, they both have prognostic factors that make the patient at higher risk for progression of the disease quickly. The prognostic factors vary slightly, and as you can see here, but the overall prognostic risk groups are the same. There's low, meaning no prognostic factors, intermediate with 1 to 2 prognostic factors, and poor, those patients with 3 or more prognostic factors. The Memorial Sloan Kettering Cancer Center model was originally derived from a group of patients who were treated with interferon. This is an immunotherapy that was used for many years in renal cell carcinoma, but no longer is recommended based on more effective treatments that we have. And the IMRCC prognostic model was derived from patients receiving VEGF inhibitors. As we talk about the treatments for metastatic renal cell carcinoma, you can see that therapy has changed, but these prognostic models have been validated in more recent treatments that we use and are still used to help determine overall treatment recommendations. Now, the first line treatment of relapsed or stage 4 renal cell carcinoma will depend on whether the patient has clear cell histology or non-clear cell histology. The most common, about 80% of patients will have clear cell histology, so we'll talk about that first. It's based upon the prognostic risk factors, so whether the patient has favorable risk or poor intermediate risk. For many years, sunitinib was a standard of care before these other options or regimens were evaluated. But as you can see, most of these regimens have been compared with sunitinib over time. Now, expanded access trials have shown that sunitinib is still effective, particularly in patients with brain metastases and those with a poor performance status. And as you'll see on the next slide, also in patients with non-clear cell histology. Currently, the preferred regimens for patients who have a favorable risk prognosis are axitinib plus pembrolizumab, pazopanib, or sunitinib. Axitinib combined with pembrolizumab improves 12-month overall survival by about 10%, progression-free survival by 4 months, and the overall response rate and benefit is seen across all groups that were evaluated in the Keynote 426 trial. Because it was seen in all risk groups, it's actually considered a Category 1 recommendation for those with poor or intermediate risk prognostic factors. Now, pazopanib is found to be non-inferior to sunitinib, but was associated with fewer side effects and improved quality of life in the COMPARES trial. So that is also why it is considered a preferred regimen. And then, as I mentioned, sunitinib has a role, particularly those with brain metastases. Now, ipilimumab and nivolumab also have shown to improve an 18-month overall survival by 14% compared with sunitinib, progression-free survival by 3 months, and an overall response rate by 15%. There were mixed results that occurred in patients who had the favorable risk, so it's only approved and considered a Category 1 recommendation for those with poor or intermediate risk. In years past, temsirolimus was shown to be the first agent that was beneficial for poor risk patients. But as you can see now, it's only used in some patients, and we have many other agents now that we can use in patients with poor or intermediate risk. Now, once a patient progresses, which they will do, the next line of therapy is a little bit less clear. What we typically would do is to base the selection based on what they received as first-line therapy and their patient characteristics, comorbidities, preferences, their medication list, the potential for drug interactions, side effects, etc. Historically, the sequential use of VEGF inhibitors was followed by mTOR inhibitors like everolimus or temsirolimus as a standard of care, but because we have this paradigm shift, we have numerous agents, it's not really clear what the best sequential therapy is. The preferred regimens at this time, based upon the data that we have, are to use cabozantinib or nivolumab first, or possibly ipilimumab and nivolumab. Axitinib and lenvatinib combined with everolimus are also other recommended regimens that are considered Category 1 and could be considered. But as you can see, there are many agents that can be used. Now, when you get to non-clear cell histology, renal cell carcinoma, there is very limited data, as most of our trials will focus on those with clear cell histology because it's a higher incidence. The role of targeted agents still warrants investigation in this group of patients. So most of the data that we have comes from expanded access, phase 2 data, or retrospective trials. And overall, they demonstrate a response rate of 36% for those with non-clear cell histology and a progression-free survival of about 6.5 months. So the preferred regimen really would be to place these patients on a clinical trial. There is some expanded access data, as I mentioned previously, with sunitinib. And then other regimens that could be used would be cabozantinib and everolimus. There are no prospective trials, but there are some retrospective data and subgroup analyses that are available for these two drugs respectively. And then useful for some patients are the other drugs that we have talked about previously, as well as erlotinib. This is the only area where we know that temsirolimus has been shown to be effective in patients who are poor risk, regardless of whether they have clear cell or non-clear cell histology. And this is an NCCN1 category recommendation. Supportive care is a mainstay of therapy for patients with metastatic renal cell carcinoma. Bone metastases, lung metastases, and brain metastases are the most common. So as you can see here, the types of therapies that we offer in terms of supportive care may be a result of those types of metastases. Surgery, radiation therapy, and optimization of disease manifestations are mainstays of supportive care. In terms of surgery, oligometastatic brain lesions can be removed with good outcomes. Patients could have malignant spinal cord compression as a result of bone metastases, so surgery may be indicated in some of those patients. And then if there are osteolytic metastases that may cause impending or actual fractures in weight-bearing bones, surgery may be indicated to stabilize those fractures. Radiation therapy can also be used for multiple brain lesions and palliation of painful bone metastases. And then we would do things to optimize anemia, anorexia, cachexia, hypercalcemia, and pain and psychosocial issues based upon our supportive care guidelines and the effects that the patient is experiencing. So bone metastases are quite common in renal cell carcinoma. About 30 to 40% of patients with metastatic disease will develop bone metastases. They're typically osteolytic lesions, and they can lead to skeletal-related events such as bone pain requiring surgery or radiation therapy, hypercalcemia, pathologic fractures, and as I mentioned previously, spinal cord compressions. The treatment would be to optimize pain management, and we can follow the NCCN adult cancer pain guidelines. All patients should receive calcium and vitamin D supplementation once they have been diagnosed with metastatic bone disease and renal cell carcinoma, and bone modifying agents can be used. In fact, zoledronic acid, 4 milligrams intravenously every 4 weeks, has been established as an effective regimen for preventing skeletal-related events and extending the time to the first skeletal-related event, and has been used for many years in the treatment of metastatic bone disease in renal cell cancer patients. Denosumab at a dose of 120 milligrams subcutaneously every 4 weeks has also been shown to be useful in these patients, and it's not considered to be non-inferior to zoledronic acid based on the results of a phase 3 study. Now, this phase 3 study was in patients who had multiple myeloma or bone metastases from solid tumors, excluding those with breast or prostate cancer. Now, it was a large study with a sample size of 1,776, but only 6% of patients had renal cell cancer. But this is the data that we have to support the use of denosumab in these patients. It did show a delayed time to the first skeletal-related event, and based upon the statistical methodology, it was shown to be non-inferior. So either zoledronic acid or denosumab can be used for patients with bone metastases and with a creatinine clearance of greater than 30 mL per hour. Now, some of our patients may have compromised renal function or even on dialysis. How we consider bone modifying agents is difficult because there is limited data on how to use these agents in that setting, but there is no standard of care currently. Now we're going to move on to prostate cancer. The treatment approach to prostate cancer depends on many factors, including the stage of disease, the Gleason score, that is how likely the disease is to be aggressive, the likely survival time of the patient, and the presence of symptoms. Now, as you might imagine, the goals of therapy vary based upon local or locally advanced disease versus advanced disease. Those with local or locally advanced disease have a high likelihood of cure. So the idea is to minimize morbidity and mortality from prostate cancer and prolong survival. Those with advanced disease, a cure is not possible at this time, so our goals of therapy are to provide symptom relief, maintain quality of life, and prolong survival as much as we can. The treatment of localized prostate cancer will depend upon the risk of disease and the expected survival time of the patient. The risk of disease progression increases with the tumor size, the PSA level, and the primary Gleason pattern, or the core number of the core numbers that have a higher Gleason pattern. Treatment options include active surveillance, which is actively monitoring the disease for progression with the intent to deliver potentially curative therapy if the disease progresses. Or observation, which is actively monitoring throughout the course of disease for progression with the intent to deliver palliative care for development of symptoms. Now, a radical prostatectomy is another option. It's appropriate for any patient with localized prostate cancer with a life expectancy of 10 years or greater and no serious comorbid conditions. The radical prostatectomy can be performed laparoscopically or robot-assisted, or it can be an open procedure. The laparoscopic and robot-assisted surgeries are used and comparable to open procedures in patients and surgeons who have experience with those types of procedures. An extended pelvic lymph node dissection is preferred over a limited lymph node dissection. Radiation therapy can also be used, either external beam radiation therapy using photon or proton beams. Various fractionation and schedules have been evaluated. And stereotactic brachytherapy is stereotactic radiation therapy is acceptable in facilities where they have that expertise. Brachytherapy may also be used, and it may be used in combination with a boost external beam radiation therapy plus or minus androgen deprivation therapy to improve disease control. Now, androgen deprivation therapy is aimed at decreasing testosterone to castrate levels less than 50 nanograms per milliliter, and that is accomplished with a luteinizing hormone-releasing hormone agonist or antagonist, or can be used with an orchiectomy.
Treatment of localized prostate cancer depends upon the risk group. In those with very low risk, treatment is dependent upon survival, either greater than 10 years, between 10 to 19 years, or 20 years or more. In those patients who have a shorter expected survival, observation or active surveillance is recommended. Radiation therapy or surgery is an option, and if adverse features are present, then use of combination therapy of surgery, radiation, or androgen deprivation therapy is recommended. In other groups, the treatment depends upon the survival estimate of less than 10 years or greater than 10 years. Lowest patients may undergo active surveillance, radiation with external beam radiation therapy or brachytherapy, or surgery plus radiation with or without androgen deprivation therapy and/or observation. Favorable risk groups are similar with the exception that a pelvic lymph node dissection is recommended with all surgeries. Active surveillance and radiation therapy are options. Combined therapy is recommended for those with a risk of pelvic lymph nodes greater than 2% or who have adverse features such as positive margins, seminal vesicle invasion, extracapsular extension, or a detectable PSA. Combining this with external beam radiation therapy with or without androgen deprivation therapy. If the lymph node disease is present, then androgen deprivation therapy with or without external beam radiation therapy is recommended. Unfavorable intermediate risk patients should also undergo combined treatment unless no adverse features or lymph node disease is present, similar to favorable risk. Active surveillance is not an option in these patients. Patients who are at high risk or very high risk or who have regional disease such as lymph node involvement are treated based upon an expected survival of 5 years or less and asymptomatic, or those with an expected survival greater than 5 years and/or are symptomatic. If less than 5 years, you would consider observing versus administering androgen deprivation therapy or external beam radiation therapy. In patients who are symptomatic or have 5 years or longer life expectancy, then combined therapy with radiation plus androgen deprivation therapy could improve outcomes by also included brachytherapy. Surgery alone with a pelvic lymph node dissection is appropriate in those with no adverse risk features or lymph node involvement, but more commonly it is surgery plus androgen deprivation therapy with external beam radiation therapy or observation, particularly if there are adverse features and no lymph node positive disease. If lymph node positive disease is present, you must use androgen deprivation therapy with or without external beam radiation therapy. In those with regional disease, external beam radiation therapy with androgen deprivation therapy is preferred. The length of therapy is not well understood, and we do know that the addition of abiraterone plus prednisone can be used. in a cohort of patients in the metastatic trial found that these patients had a favorable benefit with the addition of abiraterone and prednisone.
Now, understanding androgen deprivation therapy, which is a cornerstone of systemic therapy for the treatment of prostate cancer, is important. It is used in localized disease, regional disease, and metastatic disease. In localized disease, it can be used as neoadjuvant therapy, concurrent or adjuvant therapy, plus radiation therapy, and has been shown to prolong survival. There can be short-term use, so androgen deprivation therapy for 4 to 6 months, or long-term use, 2 to 3 years. What the exact benefit is of that short-term versus long-term, whether you use 4 months versus 6 months, 2 years versus 3 years, is still considered controversial. We don't have head-to-head comparisons of those. Options include an LHRH agonist, an LHRH agonist combined with a first-generation anti-androgen, or an LHRH antagonist. Regional disease, androgen deprivation therapy can be used as neoadjuvant therapy, concurrent or adjuvant therapy plus radiation therapy as well, and has also been shown to prolong survival. The options include orchiectomy, plus or minus abiraterone with prednisone, an LHRH agonist or antagonist combined with abiraterone and prednisone or given alone, or an LHRH agonist plus a first-generation anti-androgen. For patients who have localized prostate cancer, they may relapse, and it may happen after the completion of local therapy or during observation or active surveillance, or it could happen while they're on androgen deprivation therapy. What we do depends upon when they have that recurrence. So if it's after the completion of local therapy or while they're receiving active surveillance or undergoing observation, we would look at the PSA levels routinely. When the PSA level starts to rise, so greater than 2 nanograms per milliliter above the lowest point that they reached, we would consider local therapy if they have not already received that, or we may watch them or initiate androgen deprivation therapy. It somewhat depends upon patients' comorbidities and their overall discussion that the patient has with the treatment team. If they have a rising PSA while on androgen deprivation therapy, there are 3 options. For a long time, what we would do is continue androgen deprivation therapy and possibly consider the addition of a first-generation anti-androgen. However, more recently, we have some data that suggests that if the PSA doubling time is less than 10 months, this is a more aggressive form of prostate cancer, and the addition of a second-generation anti-androgen can be beneficial at delaying the time to the development of metastatic disease. If the PSA doubling time is longer than 10 months, we would consider observation or a secondary androgen deprivation therapy, such as a first-generation anti-androgen or possibly ketoconazole or some secondary corticosteroids. For those patients who would be eligible to receive a second-generation anti-androgen in the setting of non-metastatic castrate-resistant prostate cancer, defined as a PSA doubling time of less than or 10 months while on androgen deprivation therapy, could receive one of the 3 available second-generation anti-androgens, apalutamide, darolutamide, or enzalutamide. The key eligibility criteria from the pivotal trials are listed here for you, as well as the efficacy, dosage, and toxicities. As you can see, all 3 of these trials were looking at the median metastasis-free survival, and overall, the addition of a second-generation anti-androgen significantly improved that time to the development of metastases, similarly among all 3 of these. No head-to-head trials have been compared or conducted of these 3 agents. We just have the individual trials compared with placebo currently. Apalutamide and enzalutamide can be given daily, and it doesn't matter if it's with food or without food. Darolutamide must be given twice a day with food. The toxicities they're relatively well tolerated. Some of the toxicities may differ as shown here for you. For example, apalutamide is associated with hypertension, a rash, fracture, and hypothyroidism. Darolutamide is very well tolerated. The most common is fatigue, extremity pain, and rash. And enzalutamide also is most commonly associated with fatigue, but also has hot flashes, hypertension, and falls associated with it. When patients develop metastatic prostate cancer, The data supporting first-line treatment relies on the patient receiving androgen deprivation therapy. So once a patient starts androgen deprivation therapy, it is for the remainder of their life. Suppressing testosterone levels is the primary mode of treatment. At some point, the patient may progress while on androgen deprivation therapy because of the development of new pathways for prostate cancer growth. So in metastatic prostate cancer, the goal or the treatment paradigm is that we continue androgen deprivation therapy and we add on additional agents. There are many different agents that are available to be used for metastatic prostate cancer combined with androgen deprivation therapy. These have not been compared head-to-head, so we don't have data selecting one agent over the other, and they're usually based upon the patient's life expectancy, comorbidities, preferences, things like insurance, whether they're able to be adherent to oral medications, and et cetera, those sorts of things. The options include docetaxel given for 6 cycles, abiraterone and prednisone, or fine particle abiraterone combined with methylprednisolone, apalutamide, enzalutamide, or in patients with low volume disease only, you could consider external beam radiation therapy to that primary tumor. The clinical trials, as I mentioned, have not been compared head-to-head to date. The 4 systemic agents that are used combined with androgen deprivation therapy have been compared to androgen deprivation therapy alone, placebo, or the standard of care. This table demonstrates the efficacy of all 4 of these agents, and as you can see, the primary endpoints differed in each of these trials as well as the inclusion criteria. This is more fully described in the outline, but I would suggest that you take a look at this information. The primary endpoints in all of these trials were significantly improved with the addition of these agents to androgen deprivation therapy, with the exception of the Getog AFU 15 study, which evaluated docetaxel. Criticism has been given to this study because patients had additional therapies after they received the docetaxel, which may have improved overall survival and altered the outcomes of this particular study. And a meta-analysis has confirmed benefit with the addition of docetaxel for 6 cycles, as well as the results of the CHARTED and the STAMPEDE trials. So again, the selection depends upon the patient, the disease, and the drug characteristics. At some point, though, patients will go on to develop resistant disease, and they'll have what we call metastatic castrate-resistant disease. Again, we would continue androgen deprivation therapy to keep that castrate level of testosterone. It's important at this point in therapy, once they relapse, to evaluate the tumor for any microsatellite instability or deficiency in MMR, because that may allow the patient to have benefit from a checkpoint inhibitor. We would also perform genetic germline testing. At this point in time, bone resorptive therapies would be used if the patient does have bone metastases, either denosumab, which is a category 1 recommendation by the NCCN, or zoledronic acid. Palliative radiation therapy may be used. Supportive care is very important. And then the determination of the second-line treatment is really dependent upon the tumor and the metastatic site, because we don't have optical sequencing data available. Most studies evaluated treatment for metastatic castrate-resistant prostate cancer had patients who did not receive primary androgen deprivation therapy. Thus, the optimal first-line and subsequent regimens are not quite yet identified. Treatment of castrate-resistant metastatic prostate cancer depends upon when they have been diagnosed. Most patients will have adenocarcinoma, and the treatment varies slightly based upon the presence or absence of visceral disease. Now, castrate-resistant metastatic prostate cancer can occur after a patient has been treated for hormone-sensitive metastatic disease, meaning they were diagnosed with metastatic disease and then treated with androgen deprivation therapy plus another therapy, and then went on to have progression. Or they could have non-metastatic disease, be on androgen deprivation therapy, and develop metastatic disease, which automatically makes them castrate resistant. So determining what the first-line treatment is depends upon what they had received previously if they had hormone-sensitive metastatic disease. In those patients who have developed castrate-resistant metastatic prostate cancer, the first-line options include docetaxel and enzalutamide, because there is the most significant data based on phase 3 clinical trials showing that patients did receive a benefit in this population. However, if they had hormone-sensitive metastatic disease and received docetaxel or enzalutamide up front, we would want to move on to one of the other agents. Second and subsequent line treatments are listed there for you on the right-hand side, and those in blue are considered NCCN Category 1. Now, patients who have no visceral disease have several more options available to them. The studies that evaluated these drugs in the treatment of castrate-resistant metastatic prostate cancer include abiraterone and prednisone, docetaxel, enzalutamide, radium-223, but only for patients who have bone metastases only, and Sipuleucel-T can be used. Second and subsequent line therapies are many of the same drugs, but also include cabazitaxel as NCCN Category 1 recommendations, and then there are a variety of others where the evidence isn't quite as strong. Now, patients who have castrate-resistant metastatic prostate cancer could also have small cell or neuroendocrine tumors, although this is much less common than adenocarcinoma. In these patients, we treat them very much like other small cell or neuroendocrine tumors with the combination of a platinum plus etoposide or docetaxel plus etoposide. Clinical trial is also a very good option because we have very few trials that have patients with this type of prostate cancer. And as with all prostate cancer patients with metastatic disease, the best supportive care continues throughout therapy. Now, supportive care in prostate cancer focuses a lot on bone health. And the reason for that is that androgen deprivation therapy can cause a decrease in testosterone and therefore places the patient at high risk for developing bone loss. Additionally, patients are likely to have bone metastases in metastatic disease as the most common metastatic site. In those patients who are receiving androgen deprivation therapy and are at risk for bone loss due to the suppression of testosterone, they should be evaluated for this potential bone loss. So we would evaluate the fracture risk using the FRAX screening tool that requires a baseline DEXA scan if there is an increased risk. So all patients who have been on androgen deprivation therapy for 1 year or longer should have a DEXA scan and vitamin D levels assessed. At the start of androgen deprivation therapy, calcium at a dose of 1,000 to 1,200 milligrams per day and vitamin D 400 to 1,000 international units per day should be administered and continued throughout the duration of the patient's androgen deprivation therapy, which is typically for the remainder of their life. Anti-resorptive therapy could be initiated in patients who are 50 years or older with a T-score on DEXA scan of -1 to -2.5 at the femoral neck, total hip, or lumbar spine, and a 10-year probability of hip fracture of 3% or greater, or a 10-year probability of major osteoporosis fracture of 20% or greater. In these men, anti-resorptive therapy with denosumab, zoledronic acid, or alendronate at the doses and schedules listed there for you are recommended. These are the doses that we would use in patients with osteoporosis. Now, those with bone metastases are at risk for skeletal-related events, similar to what we talked about with renal cell carcinoma. And in these patients, men with metastatic bone lesions and who have castrate-resistant disease can receive denosumab given more frequently, 120 milligrams subcutaneously every 4 weeks, or zoledronic acid, 4 milligrams intravenously every 4 weeks to prevent these skeletal-related events. We don't know what the optimal duration is. Some of our metastatic castrate-resistant prostate cancer patients can survive several years now with the advances that we have in overall treatment of the disease. What we do know is that denosumab has been shown to be similar in terms of the incidence of SREs and superior to delay the time to the first SRE. Hypocalcemia is much more common than it is with zoledronic acid, and calcium vitamin D supplementation and routine monitoring is required. Zoledronic acid, you always have to remember the dose is adjusted based upon the creatinine clearance, and neither of these drugs is recommended when the creatinine clearance is less than 30. Now, osteonecrosis of the jaw is something that is related to both RANK ligand inhibitors as well as bisphosphonates. It tends to increase this risk of development when patients have tooth extractions, poor dental hygiene, or dental appliances. So because of this, a dental exam should be performed before therapy starts, and any tooth extractions or any sort of surgical dental procedures should be well healed before the patient starts therapy. If they need an invasive procedure, that we would withhold the bone modifying therapy and initiate it again once the patient is well healed. Now, it's important to know that there is no benefit shown when patients have metastatic hormone-sensitive prostate cancer to use these agents. So this is only used right now in the castrate-resistant metastatic setting. Other toxicities related to androgen deprivation therapy include sexual changes, hot flashes, loss of muscle mass or fatigue, and metabolic changes. So things that we can help with are education and sexual health counseling. The phosphodiesterase type 5 inhibitors have shown variable efficacy. It's something that could be considered, but we would recommend that you refer these patients to specialists in sexual health, because they may be able to also offer mechanical devices and penile injections. Hot flashes are common with all androgen deprivation therapies. We would tend to lean towards non-pharmacologic treatments, avoiding caffeine, alcohol, hot spicy foods, have layered clothing, etc., exercise. But in patients where those are not effective and hot flashes are disrupting their sleep significantly, we can use drugs like venlafaxine or gabapentin. We typically start at a low dose of venlafaxine, 37.5 milligrams by mouth daily, and this has been shown to reduce both the number and the intensity of hot flashes. Gabapentin seems to be dose dependent. Usually we would titrate up slowly, and it has been shown to moderately decrease the number of hot flashes. So venlafaxine, if not contraindicated, is probably our drug of choice, although these drugs have not been compared head to head. We encourage regular exercise because that will help with loss of muscle mass and fatigue, as well as metabolic changes that can occur because of the long-term suppression of testosterone. And risk reduction treatment and ensuring the patient follows healthy lifestyle as well as primary care evaluation for diabetes, hypertension, and cardiovascular disease is extremely important. And finally, we're going to touch on testicular cancer. Testicular cancer is one of the most curable cancers, and even for metastatic disease, the goal of treatment is a cure. The general approach to testicular treatment is based upon a histology, whether the patient has a seminoma or a non-seminoma cancer, the prognostic score based upon the International Germ Cell Cancer Collaborative, which is a prognostic scoring system based on tumor markers following surgery. As well as surgery, orchiectomy is performed at the diagnosis of all patients. A retroperitoneal lymph node dissection is recommended for all patients undergoing orchiectomy, but it's only done in some tumors, and it really should only be performed at high volume centers. Data has shown that when it's done at a low volume center, that the efficacy of this is not as high. Radiation therapy is also something that can be used particularly for early stage seminomas, and it is initiated after orchiectomy heals to avoid the complications. And it also requires antiemetics at least 2 hours before treatment. Because of the radiation field aimed at the lower abdominal area, nausea and vomiting is very common with this treatment. Now, this is the prognostic scoring system that I mentioned previously. The risk status is good, intermediate, or poor, and it's based upon whether or not the patient has non-pulmonary, visceral, or mediastinal metastases, and what their levels of alpha-fetoprotein and beta-HCG, as well as LDH are following surgery. As you can see, for those patients who have no non-pulmonary, visceral, or mediastinal metastases and have low levels of tumor markers, they have an overall good risk status. Their prognosis is very high. But those with high levels of tumor markers following surgery or have the possibility of these mediastinal or non-pulmonary visceral metastases have a poorer risk. Treatment, as I mentioned, is based upon whether or not the patient has seminoma or non-seminoma. This slide here shows you the various options for the different types of clinical stages and risk group. Risk group is not really applicable until you get to stage 2C or 3, but in the earlier stages, what we can offer is surveillance or single agent carboplatin, radiation therapy, or a combination chemotherapy regimen, which is bleomycin, etoposide, cisplatin, or BEP, or just etoposide and cisplatin, EP, alone. Single agent carboplatin for one cycle was compared with radiation therapy for stage 1 seminoma and found a similar relapse 5-year survival rate of 96% with radiation therapy and 94.7% with carboplatin. The absolute risk reduction for relapse was 6.2%. Thus, the value of adding just a single agent carboplatin dose for one cycle versus using radiation therapy has been questioned, but each of these are considered options within the NCCN guidelines. For stages 2A or 2B, 2 non-randomized retrospective studies show that the 5-year overall survival was significantly higher with radiation therapy or not different compared with chemotherapy in stage 2 patients, but no difference was found in stage 2B patients. So either radiation therapy or BEP is recommended. And in stage 2C and 3 patients, BEP is preferred for good risk stage 2C and good and intermediate risk stage 3 patients. Now, if you're giving BEP, you only have to use 3 cycles, but if you're using etoposide cisplatin, 4 cycles is recommended. VEP, which can be used in patients with intermediate risk 2C or 3, is reserved for patients who have contraindication for bleomycin. That would be reduced or borderline renal function, those greater than 50 years of age, and can be an option in these patients. Now, in patients with non-seminoma, the first-line treatment is listed here for you and tends to be more related to whether or not they have markers, elevation that's persistent, or they're a risk group. In stage 1 non-seminoma, the survival rate is 98% with surveillance or nerve-sparing retroperitoneal lymph node dissection. BEP for one cycle can reduce the risk for relapse, so that is an option as well. In stage 1S to stage 2C, BEP for 3 cycles or EP for 4 cycles is preferred. As you can see, in some of these patients who have negative markers, they may be able to use a nerve-sparing retroperitoneal lymph node dissection. But remember, this should really be only done at a high risk or high volume center that is very familiar with using this surgical technique. In those patients who have non-seminoma, the first-line treatment for stages 2C through those patients who have brain metastases are listed here for you. You can see that BEP for 3 cycles or EP for 4 cycles is the preferred regimen for stage 2C or 3A. But once they develop 3B or 3C, BEP should be given for 4 cycles. And in those patients who cannot tolerate bleomycin, VIP may be used. In patients with brain metastases, they tend to have a decreased overall response rate. BEP is typically preferred if possible, and you might give radiation therapy to the brain or surgery to remove a brain met if possible. Now, those patients who have relapsed or refractory testicular cancer, what we do next depends upon whether or not they've had prior chemotherapy or no prior chemotherapy, and whether their relapse was early, so less than 2 years after completion of their chemotherapy, versus those who have a late relapse greater than 2 years after completion of chemotherapy. Those with an early relapse have a more aggressive disease. In those patients, we would actually prefer to enroll them on a clinical trial because we don't have good data for these more aggressive types of refractory testicular cancers. You could use the regimens VEIP or TIP. VEIP is vinblastine, ifosfamide, or cisplatin, and TIP is paclitaxel, ifosfamide, cisplatin. You could consider high-dose chemotherapy with an autologous stem cell transplant, or possibly surgical salvage if it's a solitary site, such as a lung met or a brain met. In those patients who have a late relapse, that's defined as greater than 2 years after completion, surgical salvage, if the site is resectable, is the primary mode. Again, putting them on a clinical trial is an option using these other chemotherapy regimens, or high-dose chemotherapy with stem cell transplant is appropriate. In those patients who have only had a surgical or radiation therapy and no prior chemotherapy, we would treat with BEP or EP as you would if it was the initial treatment. Now, these patients are likely to survive long-term, so testicular cancer supportive care is crucial in these patients. One of the main toxicities that can occur with these bleomycin-containing regimens is a pulmonary toxicity. Within 3 years after therapy, it's about 46% incidence. And most times these patients have mild or self-limited symptoms. The risk and the concern is the long-term development of pulmonary fibrosis, which occurs in only about 10% of patients. So what we do is to try to limit that risk of pulmonary fibrosis as well as pulmonary toxicity. We know those who are high at risk are those with an older age, greater than 50, anybody with renal insufficiency, receiving concurrent radiation therapy, or those patients who receive more than 400 international units cumulatively. So the idea is that we avoid those patient populations, we keep track of the cumulative dose, and we don't go over 400. Now, the symptoms of pulmonary toxicity caused by bleomycin include non-productive cough, dyspnea, pleuritic or substernal chest pain, fever, tachypnea, crackles, lung restriction, or even hypoxia. It can occur anytime, but typically between 1 to 6 months after treatment. Occasionally, it can occur during treatment as well. If it is occurring during treatment, then we would stop the bleomycin permanently. We would give symptomatic treatment. If it's afterwards, we could consider giving glucocorticoids, particularly if the patient is having significant toxicity. And it's thought that it's a good idea to avoid high inspired fractions of oxygenation, as that has been shown to sometimes cause more rapid development of toxicity. The other supportive care that we consider with testicular cancer is based upon the long-term toxicities of these patients who are lucky enough to be cured of their disease. They can have cardiovascular disease, which has been shown to be a 2 to 5-fold increased risk to a man without testicular cancer following 10 years of treatment. So we would follow standard survivorship guidelines. I would encourage you to refer yourself to the supportive care module for more information about some of these toxicities. As we know with cisplatin toxicity, there's a metagenesis, nephrotoxicity, and neuropathy, and that is all talked about in supportive care. Also, infertility and hypogonadism is very common with testicular cancer. Over 50% of patients will develop infertility from the disease or the treatment, particularly the chemotherapy. So we offer sperm banking prior to orchiectomy for patients, and that will allow about 50 to up to 90% of patients to successfully have children following their testicular cancer treatment. We can also evaluate testosterone, luteinizing hormone, and follicle stimulating hormone if a patient is experiencing symptoms after their treatment that may cause them to have hypogonadism type effects. Psychosocial issues such as chronic fatigue and anxiety are not uncommon among testicular cancer patients, so supporting them with those and giving psychosocial support is a really important part of care. Additionally, secondary malignancy, both leukemias and solid tumors, are higher in patients with testicular cancer. Secondary malignancies with solid tumors, with leukemia can increase both from radiation therapy as well as cisplatin and etoposide. There appears to be a 3-fold risk increase after receiving radiation therapy, and the risk with cisplatin and etoposide is also common. Solid tumors, the risk increases after 5 years of treatment and is a variety of primarily abdominal area solid tumors, including stomach, pancreas, pleura, bladder, colon, esophagus, melanoma, thyroid, kidney, and sarcoma, and could be related to the radiation field. Another area that is something to be aware of is the venous thromboembolism risk is higher in these patients, and they may benefit from prophylaxis. It will depend upon the patient's specific characteristics. Those who have large retinoperitoneal lymphadenopathy, who may have a high-risk Corona score, an elevated LDH, or a high body surface area are going to be at higher risk. So I would encourage you, as you're thinking about your testicular cancer patients who may have retroperitoneal lymphadenopathy or elevated LDH, that you calculate a Corona score on them and refer yourself to the guidelines through NCCN for VTE prevention and treatment. So in conclusion, the treatment of bladder cancer differs based upon muscle invasion of the tumor. Those with non-muscle invasive bladder cancer are typically treated with a TURBT followed by intravesical chemotherapy. Non-metastatic muscle-invasive bladder cancer is treated with cisplatin-based neoadjuvant chemotherapy followed by cystectomy when possible, or chemoradiation therapy for patients who do not prefer to have their bladder removed or are unable to based on comorbidities. Treatment of metastatic muscle-invasive bladder cancer is based upon the ability to receive cisplatin or not. Treatment of renal cell cancer differs based on stage. Early stage renal cell cancer is treated with surgery, and metastatic renal cell cancer is based upon prognostic risk and includes targeted therapies as well as immunotherapies. The treatment of prostate cancer is also based on stage. Early stage prostate cancer treatment depends upon risk factors, life expectancy, and symptoms, and includes active surveillance, observation, surgery, radiation therapy, and/or androgen deprivation therapy. Metastatic prostate cancer is treated with androgen deprivation therapy and chemotherapy or additional hormonal therapy. Finally, treatment of testicular cancer is based on histology and stage. Treatment options include orchiectomy plus surveillance, chemotherapy, or radiation therapy, and testicular cancer is highly curable. Thank you.